One. Hi guys, Sarah Brecker, Director of Marketing at VirtualHealth, back here for another Future Care Chat episode, and this one's extremely special. We've got our Director of Solutions Architecture from VirtualHealth, FHIR Khan, joining us again, but this time we've got two special experts. Michael Lenzer, founder and CEO of Itiliti Health, you've seen come speak with us before, and we're excited also to welcome Vice President of Federal Affairs at WEDI, Robert Tennant.
Rob Tennant as Vice President of Federal Affairs with the Work Group for Electronic Data Interchange, a consortium of payers, providers, SDOs, government, all seeking to understand and make health IT work a little better in today's environment.
And I'm Michael Lenzer, founder and CEO of Itiliti Health. We are focused on providing tools and software solutions for health plans to streamline and automate the prior authorization challenges.
Hi everyone, FHIR Khan here, Director for Solution at VirtualHealth. My job really is driving interoperability forward, particularly as it pertains to the domain of FHIR in the current healthcare tech landscape.
Well, viewers, if you haven't figured out, we're obviously going to come in here and talk about FHIR and prior auth, because if you tuned into a Future Care Chat with Michael and Con a couple months ago, you might have heard Michael mention that there was a 30-month mark here for the CMS regulations coming up into CMS 57F, and that was in July. So we're really kind of coming up on what we consider the time crunch to get ready. This episode is going to have us look ahead with these experts around what's next for data interoperability, the challenges and expectations we're expecting over the next couple of years as the prior auth and API regulation requirements come into a head, and then finally, what these experts' predictions are for the industry over the next 3 to 5 years.
Boy, where do you start? I think we could spend a week discussing this. I'll talk about the positives first, and then we can talk about the challenges a little bit later. We are really at a tipping point in healthcare. Healthcare traditionally has lagged behind other industries. So for example, you want to take a trip on vacation, the first thing you do is you go on your phone and you use an app to book a flight. It used to be you called a travel agent. Those days are gone. And healthcare is moving in that direction. That's the good news. The more challenging news is it's not going to be an easy transition. I think this is only the beginning of the deployment of FHIR-based technology to solve some of healthcare's data exchange issues.
One thing that I'll tie on to what Robert just mentioned is about how we have all of this technology and this interoperability in other industries and other domains that's now really starting to come to healthcare, where you can book things online, you can view your results, you can keep a track of where you've been from a health journey perspective. The challenge that we have in healthcare when you're comparing it to something like the travel industry is that travel is dealing with flights, with hotels, with most of which follow a fairly standard structure and generally don't tend to deviate that much. The struggle that we have with healthcare, and really the reason that interoperability is now seeing this massive push in a new direction, is that healthcare is dealing with humans. Healthcare is dealing with an ever-evolving science in the way that we store and then manage this information. And I think the next few years are really going to help us, particularly from a FHIR perspective, understand what those standardizations look like to try and get us as close as possible. For me personally, I think the next few years are going to be so important in getting us to a point where we're at least close to par with some of these other industries.
And I'd add that one of the interesting dynamics for healthcare is that most of the electronic medical record systems were deployed and built sometime before multi-tenant applications and cloud-based computing was the standard. And because those systems all have very customized on-prem types of solutions, it makes it even harder to generate activity between two systems because each system is deployed differently. The heavy lift of getting those systems to talk a standardized language between them has really been waiting for a major application initiative that really forced the issue. And that's what I find so compelling about the prior authorization use case. In this particular case, interoperability between payers and providers has typically been an area where either payers wanted the data or providers wanted the data, but there wasn't a dual purpose. Both sides of the equation weren't motivated. This marketplace with prior authorization is unique in that both parties recognize the need to make this transition happen. What it's going to take to make it successful is the ability for these changes between payers and providers to be able to be implemented in such a way that they can evolve, that they're not too heavy of a lift before each party gets some benefit, and then from there can grow in value. So I think that's the key for success of the new interoperability for prior auth, is making sure that there's value closely related to the effort. Is unlike the patient access APIs where health plans have told us that they've implemented lots of things and they haven't seen much value. Prior authorization has the potential with some of the earliest portions of interoperability to bring a lot of value to the user.
Maybe I can build on that. We talked about healthcare being different from other sectors. Candidly, prior authorization is different from other healthcare transactions where it's a one-on-one, very simple claim submission, and there is clear ROI on both sides to automate. Prior auth is not quite like that. Prior auth, as one physician once told me, it's a conversation. It's not a transaction. It's complicated. I think one of the things, and Michael, you're 100% right. One thing we need to do as an industry is prove the return on investment. And I'll tell you why. The rule is unique in that it doesn't require everybody to comply with it. It only requires certain health plans. In general, the commercial health plan world is not required to adhere. So how can we convince a health plan that is not forced to do it? How can we convince them that it's in their best interest to do it? And that's part of the role that WEDI will play over the next few years. Health plans, the ones that are already starting to do this, to kind of show how they did it, the value that they're receiving from this, their call center volumes are down, that they're seeing a clear return on that investment. And that should help convince other plans. The other issue is, does a health plan who has a Medicare Advantage line of business and a commercial line, do they want to have two separate ways of doing prior authorizations, or does it make more economic sense to merge both into the API world? Another one is not all prior authorizations are covered under the rule. For example, drugs, which are a big part of the authorization world. If your physician prescribes you a drug, but it's not covered under your formulary or requires a prior authorization, that's a huge burden. In the spring 2024 unified agenda, there is a placeholder from CMS that would include drugs in this PA world. So that will be a very important component. Again, not just to convince the payers, but how do you convince the providers to invest in the technology?
I would agree with that. One of the things that we've seen that's helped our clients be motivated to implement these solutions is the ability to take some of the initial requirements of supporting and use that same data and structure in their portal applications. As a great example, the first transaction in the prior auth specifications is the CRD, or coverage requirements discovery. How many organizations are thinking of that as a solution that they build just to support CRD? When in fact, what we've found is delivering that same function, a very easy to use, accurate lookup tool that can determine whether or not a prior auth is required and what some of the details are for that requirement. That drives tremendous value to the health plan even before they get to those CRD interfaces. So it's a great place for health plans to start to show an ROI, and then they can add on the interfaces, and it's a win-win for them. They're checking the box, but at the same time, they're getting a tremendous amount of value.
If I can just add some thoughts on the CRD, because I agree. It's the lightest of the lifts, but it's arguably the biggest bang for the buck as well.
Right.
What we've heard from health plans is there's a tremendous call volume from providers asking if a particular medical service requires it, only to find out that it does not. So it's why did you bother calling us? You don't even need a PA for that. But here's some issues with the CRD. It seems like it's very simple. It's a yes or no answer. Life is not simple. It could be, it depends answer. For example, your physician orders an MRI. Usually that requires a PA from the health plan. Well, the health plan may say, it depends. Did the patient get an x-ray first? Because we require that before we would authorize. And so, Sarah, to one of your questions about where is technology going in the next 3 to 5 years, here's an opportunity, intelligence, where the health plan can quickly look to see if the provider has submitted a claim. Now they know the x-ray's been performed. They can automatically say, you can do the MRI because we see you've already conducted this prior service. So I think the better information the health plan has in their databases, the quicker and more accurate information they can provide to the provider. But there's a couple of other challenges ahead. One is the trust factor. If the provider says, I want to do an MRI, they go ahead and put through the CRD, it comes back, no, it does not require it. They go ahead and perform the service and submit the claim. The claim is denied because the health plan says that required a PA. How can we trust the answer? So there's got to be a guarantee that if the answer is no, that the claim will be paid. And that's going to be a big piece. The other challenge is that the way the regulation was written, there is not a requirement for the health plan to adhere to the implementation guide. It is recommended, but it is not required. So if the health plan decides that they are going to adhere to the implementation guide up to the point of real-time response to the provider on the CRD, if they decide get back to the provider in a week or a month, then that's not going to work. For this, it has to be real time, or the provider will say, I'll just go to the portal or I'll get on the phone. So that's going to be critical if the health plans adhere to the full implementation guide.
There's a few things that I want to touch on that both Michael and Robert mentioned prior to this, which is that there's that process of the adoption of FHIR across the industries and kind of how that's been a relatively incremental process across the board. CMS initially came out with the rules for the provider directory API, the patient access API, and the payer-to-payer API. And something that both Robert and Michael mentioned before is if you build it, people will come. But there was a very interesting thought behind those three in particular. The provider directory was arguably the most simple of the sort, but is likely the one that's most used compared to the patient access and payer-to-payer provider APIs. I would love to see more use of it. But the benefit that I saw of that was that kind of like payers dipping their toes into it using business processes that are relatively non-critical to the day-to-day operations of the health plans and the patients and the provider. Then you come to the prior authorization API rule, which is something that is used day in and day out. We have a client at the moment partnered with Itiliti that we've implemented the prior authorization API for, and it is used constantly. Like it's happening day after day, hour after hour, minute after minute. And I think that that was possible because it was introduced in a relatively incremental fashion using processes that weren't as business critical or as compliance critical, simply because of the rate at which they were happening as prior authorization is. There is one other thing as well that I think is coming forward that Robert mentioned about the CRDs. So the CRD, when you're looking at the more complex rules behind prior authorization, does this person or has this person had that x-ray in order to say that you don't need a prior authorization for this MRI? And that's where we believe from health perspective, that's where FHIR becomes really important. So the situation of the CRD where it's not a simple, straightforward yes or no, right? The way that we integrate with Itiliti is we send them a FHIR bundle and we say, using the implementation guides provided to us, these are all of the pieces of information for this person. Please see if there's a prior authorization required or not. Now, let's go down the route of someone requesting that MRI. If that and says, I can't make a determination yet because I need to know this additional info. If that rule set is at least remotely standardized, and this is one of the reasons that we created Hub to develop a FHIR store that is in sync with all of the different systems that are being worked within a health system, Itiliti using the FHIR-based API, something that is open source, something that is understandable by everyone, it follows the standard API architecture across the technology industry, they can run a query into Hub's FHIR store and say, are there any observations or are there any service requests or claims that have this code or these codes, or are they classified as an X-ray? And if they receive something back, then they can say, cool, the patient has done it. I'm going to approve this API before returning it back or approve the prior authorization or say that it's not needed prior to returning it back. And coming back to what Michael brought up at the very beginning of this around how ancient some of our EMR systems operate in terms of the data structures and stuff that they use, the value that we get out of FHIR is that now it doesn't matter which rules engine or which portal is trying to look for this stuff. The query that they execute across any of these systems is the same. And that's what we're really trying to drive towards from an interoperability perspective, is that internally within your applications, use whatever data structure you want that optimizes the operations that are happening within it. But once those operations have happened and you have an outcome for a patient or a piece of information that's really useful to the other systems around it, you have it in FHIR. And now anyone who wants that knows exactly how to query for it, how to interpret it, and how to use it for whatever business processes that they need after that point.
Yeah, I think points to something that we've done together with VirtualHealth in the way we've implemented our solutions, in that we're doing things that support a use case today. And in some cases, we do things over and above what the requirements are in order to facilitate a well-working function. But at the same time, we've laid the groundwork for many capabilities in the future.
So you guys have all sort of touched on some of the challenges and the expectations for the next couple of years, and I think it paints a good picture. So thinking through the smaller steps we might need to take, the challenges you brought up, like the complexity of what we're dealing with, and where does FHIR help sort of simplify this across the board moving forward to make this better? And I think this actually helps go back to ROI as well, thinking through like, how do we prove this out? Because yes, there's the numerical value that's going to come down to a lower call volume and eliminating unnecessary prior authorizations, cost savings at the operational level within the organization for payers, providers, and the health systems themselves. But if you guys had to pick one key challenge you expect to see between 2025 and 2026 within the relationship of this CMS ruling, as well as the state ones that have come out, what would be right there at the top for the next 2 years?
I mentioned it before. This is only going to work if everybody gets on board. If this is just another method of doing a PA, if it's 5% of your PAs and you do most of them in the portal or you use your fax machine, it's going to be a real challenge. I think we've got to convince two groups, payers that are not covered under the rule, but also the providers that are not covered under the rule. So the rule essentially says, provider, if you are engaged with CMS in its incentive programs, then you will have to show that you're using the technology. But there's a lot of providers that don't. There's a lot of folks that do not use ONC certified EHRs. So one of the things that's important is ONC just released a rule which sets new certification standards. At least it's a proposal to include the APIs in these certification. So one of the goals and one of the challenges is to convince ONC to create additional certification programs to cover these other types of providers that are not currently involved in the CMS incentive programs. So there's a lot of work ahead, but if it can be done, I think it will really push this forward.
For me, like CMS, they don't even have the jurisdiction really to enforce those kinds of processes on the commercial world when it comes to the payer side of things. But they have done something quite smart, because the things that they are introducing at the moment are directly related to pretty much any standard operation that commercial payers do that are a part of Medicare and Medicaid. But the difference is going to be what Robert brought up before, that any health plans or payers aren't going to want to have to do two separate things for both of their populations. So what do? You generally try and take the path of least resistance. Now, the least resistance aspect of it, when you consider it from a health plan perspective, is this costing us money? Is it saving us money? Is it making us more efficient? Does it give us the ability to generate more revenue based off the delivery that we are providing for our members? And I think that's just going to happen inherently. I think the operations and the APIs and the rules that CMS are pushing out for Medicare and Medicaid health plans are going to see the inherent benefit that you have with those, and they will be encouraged to push that over to the commercial side of things because of the benefit that they're going to see. Whether or not that does in some way need to be compliance related to really push for it is a different story. My prediction is these larger payers will kind of lead that charge to say, well, it makes sense here. We have most of the infrastructure and we understand it. We're going to implement this on the commercial side, and we can now just operate under one particular model across the board. That's going to encourage and drive adoption of that, not only from a provider perspective for the ones that want to be involved with the Medicare and Medicaid services, but also for the other plans that see the benefit and they say, okay, there's no point in not doing this because everyone's kind of moving there themselves. The challenge is going to be pushing these payers who are on the hook for the 0057F rule to get started sooner rather than later. I mean, Michael and I had a whole conversation basically geared towards saying, get onto this sooner rather than later. And there are two reasons for that. One is that if you haven't started your FHIR adoption, that is something that you absolutely need to do if your compliance is going to be directly tied to this. The second thing, and this should be a really important part of a organization's consideration, is the sooner you start implementing it, the sooner you start to see the gaps. This final rule is, by most CMS standards, not final. It's why the enforcement is all the way through to the end of 2026. The sooner we get involved, and this is exactly the benefit that Itiliti and us are seeing, having done this for a client already, is we can now go back to CMS. We can now go back to the Da Vinci working groups who are handling these implementation guides and say, hey, yes, most of this stuff got addressed, but in the real world, there are some issues here. There are some gaps that we need to address. There are some considerations that we, as people implementing this, have come to realize that we think should be incorporated, not just as part of the final rule, but for the implementation guide being used for it. What this allows for is for these health plans, not just to make sure that when compliance starts in 2027, and when we say 2027, we mean the 1st of January. So think about it more like the 31st of December 2020. Not only do you get the opportunity to influence that prior to the compliance starting, right? But you also now get to add considerations that you might think about for your commercial plans, so that when you do decide to adopt it, those things are already there. They aren't things that you have to add or modify or update. You can kind of push those towards it and say, hey, CMS, we want to do this, but we don't want to complete two separate functions. Add this to it. It will help us. It will encourage us. It'll make it easier for us to be able to adopt this stuff. And so I think those challenges directly tied to benefits that, if utilized in a purposeful manner, can help drive the entire industry towards a much stronger interoperability framework than what we have at the moment.
I think you hit on kind of a great transition into one of the things that I think is the biggest challenge that's going to take place over the next couple of years, and that is that the The standards were written under the perspective that in a perfect world, when everybody is using the standards to the maximum capability, this new standard will be fantastic. One of the biggest challenges in implementing the APIs is creating questionnaires from your medical policies. It's a huge lift. And most organizations assume that they have to complete that process before their DTR capability is compliant. And that's really not the case. Those questionnaires don't have to cover every criteria element. You can also ask for documents to be sent. So we're working with HL7 and DaVinci to try and push for the ability for these systems to do a better job communicating what documents need to be attached versus what questions need to be answered. And if organizations can fully realize that opportunity to ask for documents versus converting all of their policies to questionnaires, it really lightens the load for the health plan in implementing these solutions. And it makes it easier for providers to actually comply because, again, just because there's a really nice questionnaire that a payer sends out doesn't mean that a provider's EHR system is really ready to fully answer all of those questions. And so it's an iterative evolution to the perfect world. And as you said, Con, as we've worked together and seen these things implemented at scale, it's much easier to go back to these groups and make recommendations for changes that can create a much easier to implement solution that hopefully is going to win in the marketplace.
One last thing that I'll add from an ROI perspective, because I feel like this often gets lost in the conversations that we have around, oh, how much money is this going to save me? I think something that's super important for people to think about is what I like to call like the negative ROI of implementing these processes. So imagine for a moment that implementing the prior authorization API cost you $2 million, right? Let's just assume that that's the case for the moment, for the sake of the maths that we want to talk about. And it costs you $2 million to incorporate. And at the moment, the appeals process for your claims denials or authorizations that providers have tried to use at the moment, close to 1.5 million, right? And if you're able to reduce those by 90%, you now have an additional amount of revenue that you're no longer spending because the process that you've put in place, not only has it now sped up the efficiency of the people who are executing these prior authorizations and the amount of money that you can save from making that process more efficient, but what processes is this going to reduce that are directly outside of the initial prior authorization process? What parts of your organization are now going to see less stress, right? Is your customer service line now going to receive less calls? Your appeals coordinators are going to have to go through less each day because the prior authorization process has made it so much simpler for patients and for providers that they are no longer coming back to you 3 months after the fact and saying, hey, why was this claim denied? And so I think there is a lot to have a conversation about what other parts of your operations is this going to indirect impact in a positive way, rather than just thinking about kind of how long do my prior authorizations take at the moment versus how long will they take after the API, but also how many people are going to now not have to deal with all of the aftermath of not having a robust prior authorization process like the API is trying to push for at the moment.
Let me add an important point because I think you're onto something. We have to remember, according to every provider organization, prior authorization is the leading burden and it's directly causing physician burnout. So you could argue that a health plan that has an enormous percentage of a particular market probably doesn't have as much of an incentive to move forward with this as a smaller plan that is seeking to increase its market share. Right now, it's extremely challenging, the whole physician contracting world. If a health plan can come in and say, I'm going to make the most burdensome aspect of your day easier. That could be a market differentiator, in particular for smaller plans looking to break into a particular market.
You did make me think about one more thing here. And this is something that I think a lot of people need to consider when they're looking at the industry as a whole. Not only with the prior authorization process will we see less burnout from providers, which ultimately will mean that they are providing better care to the populations that they are serving. But it also means if I have less anxiety in going to my provider and saying, hey, I want to get an authorization for this particular service, or my provider is much more willing to offer a service to me, the likelihood of addressing and preventing further deterioration of a person's health saves money for everyone in the long term, right? Ultimately, increasing and improving the efficiencies of physicians doing their role will ultimately lead to better health outcomes, which ultimately means less health spending in the long run.
You guys have given us a lot to think about, which I appreciate. So there's clearly some challenges ahead, but there's clearly opportunity, as you all three mentioned, not just for those that are mandated under these requirements, but the industry as a whole. So just want to thank each of you for joining us for this conversation, for lending your expertise today. And I'm excited to see how we all continue to have this conversation and collaborate together, as well as the industry as a whole, to push healthcare forward. For everyone watching, thank you for joining us. Jeff Hagertar. And if you have any questions, drop them in the comments.
Thanks so much.